All right. Looks like this is all we're going to get for now, but we'll go ahead and get rolling. Thank you so much for coming, Dr. Wagner. We really appreciate it. I'll give a brief bio before we get started. So Dr. Wagner completed his orthopedic surgery residency training at the Mayo Clinic in Rochester, Minnesota. After residency, Dr. Wagner did a hand and upper extremity surgery at the Mayo Clinic and then a shoulder and elbow fellowship at Harvard's International Combined Program with international leaders in Nice and Annecy, France. Dr. Wagner is now practicing at Emory University in Atlanta, Georgia, specializing in complex upper extremity pathologies. He has published over 230 peer-reviewed journal articles, delivered over 500 presentations, national and international, authored over 15 book chapters, and edited 2 textbooks. He serves on multiple journal editorial boards, is a shoulder and elbow editor for the ASSH, and serves on multiple committees at the ASES and ASSH. He received the prestigious North American Traveling Fellowship through the AOA and the Richard Gelberman Traveling Fellowship through the ASSH. Additionally, he has received numerous grants to support his clinical and basic science research interests and has received numerous national and international awards for his many upper extremity research investigations. So with that, thank you all for coming. We'll go ahead and get started. I'll turn it over to you, Dr. Wagner.
Great. Thank you very much for this opportunity. And I'm going to share my screen. Can you see this all right?
Yes, sir.
Wonderful. Perfect. So, well, thank you for this opportunity, and I appreciate everybody's time. You will open up to questions at the end. I'm going to kind of go through some research that we've been doing. There's some ongoing stuff that's still out there. We're going to get some results in the next couple of months, but I'm going to show you kind of the, one of the, I guess, big passions that we've developed in the upper extremity. And it's kind of spread across, at Grady, they're doing very similar type of things. So we're trying to understand some of these disparities in healthcare utilization, and not just how it impacts sort of like the clinic flow in Emory, but really how it affects our day-to-day lives, how it affects our community and our nation, and is there something that we as physicians can do about? And we'll talk about why I think this is important, especially being at Emory and in the city of Atlanta. So this idea of healthcare utilization disparities is not new. It was initially described in 1993 in the New England Journal, where they showed that Black patients were 38 to 122% less likely to undergo these invasive cardiac procedures in the VA system. So, you have equal access at the VA, and yet somehow there was a disparity based off of race. And this created a lot of press and a lot of investigations into, is this sort of an isolated thing, or is this something that's real? So there's sort of a follow-up study that then looked at 158 hospital regions from 1992. So when that was initially published to 2001, with all the press around it and all of these different surgeries being studied with it, and found that there was no change in the actual disparity. So these disparities continue to exist, and in some cases even got worse from 92 to 2001. So if you look at this carotid endarterectomy, you can see the disparities persisted and actually even worsened, as did CABG. And then when you look at total hip and total knee replacements, you also see that there was not a real big change in closing the gap between these disparities. And once again, this is rate per 100,000 enrollees. So this is counting for the percentage of people enrolled in this. So you can't just say there's less Black people enrolled in this, as this was standardized for that. But once again, there was a lower utilization rate with Black women and Black men compared to white women and white men. And if you look at these gaps and the number of the gaps that widened versus the number of the gaps that narrowed, you can see a much larger percentage in these studies actually widened compared to that narrowed. So despite all this press and all this attention, it seemed like nothing was actually happening. And once again, it shows that just to bring attention to something is not necessarily enough, and you actually have to do something a little bit more than just bring attention to it. So this is when it started really getting sort of national funding attention. and started government paying programs started paying attention. So when you look at this is looking at in a Medicare population, blood pressure control, and you can see once again the blood pressure control trend when dividing by race actually worsened rather than improved from 1999 to 2006. And once again, mean hemoglobin control, also that disparity somehow worsened again. So there's this non-medical problem, i.e. race, is causing a significant difference in disparity with regards to blood pressure control and HbA1c. And that was one of the studies that when you read the book Unequal Treatment, or when you really start to see a lot of the national attention from the Institute of Medicine and the NIH, that there is a real problem with these disparities. So it's not just that there's different utilization rates, but it actually impacts patient care. There's a big turning point, at least in one of the first NIH funded or nationally funded studies, came in 2003, as well as a variety of other sort of considerations. So, we are orthopedic surgeons. we all are musculoskeletal providers on this. So what about orthopedics? And I kind of showed you some preliminary data back in the first studies, but are disparities prevalent? As 50% of emergency department visits are musculoskeletal related. Many others are many other elective practices. It's a huge number of patients undergoing musculoskeletal care at any given time within the United States. And when you look at orthopedics, you can see in hip and knee arthroplasty, and this has been the area that this has been studied the most, there are very similar and persistent disparities. And these are studies more recent, so 2006 to 2015. This is a very well-done study looking at a Medicare population, so relatively somewhat standardizing for insurance status, showing that there is still a disparity from 1991 when it first started to 2018. It actually increased over the study period. And then primary total hips, it stayed about the same from 1991 to 2008. So despite a lot of attention, even some money coming in 2002, 2003 to study these and to potentially intervene on this, nothing really was moving the needle. And this is sort of, once again, showing with revision hip and revision knee, there remains this disparity, and if anything, a widening disparity in some respects. Sort of, once again, kind of highlighting the importance of utilization is as in the medical population, does this have an impact on outcomes? And so when you look at that original study, you can see that there once again is an impact on mortality. So there's a higher overall rate of mortality with the Black patients undergoing primary total knees and total hips compared to whites. Now, the primary total hips did sort of standardize through the study period, but primary total knees did not. And revisions, if anything, actually widened with regards to their disparity. Furthermore, length of stay was significant impact and actually worsened throughout the study, as was the number of patients requiring discharge to SNFs and their overall complication rates. So once again, a non-medical factor, a psychosocial factor, race, that's impacting not only utilization, but also complications and outcomes. So what about shoulder surgery? So this is, as many of you know, this is sort of one of my passions and one of the things I really enjoy. And we did this study published in JBJS looking at the incidence of compared to total knee and total hip. You can see total shoulders are increasing at a much higher rate, and are going to continue to increase. We might not ever catch total hip and total knee, but we'll come close one day. We also showed this is largely secondary to the reverse. And I think this is relevant because you'll see we kind of followed this up with a study in utilization. And this kind of piggybacked off of a couple of our other colleagues at both Rothman and in Alabama, showing that there was this persistent disparity in shoulder placements. So you can see from 2005 to 2011, there remained a disparity, and there wasn't really a big closing of that gap. This kind of interesting study. So if you looked at Black females with Medicaid compared to non-Medicaid white males, there was a 240% chance of a higher chance of treating a rotator cuff tear non-operatively in a Black female with Medicaid compared to a non-Medicaid white male. So it has nothing to do with pathology, has nothing to do with tear size. Purely insurance status and race had a huge impact on how these patients were treated with regards to their rotator cuff tears. I mean, that's mind-blowing that actually is this big of an impact. So those are kind of historical studies back 10, 15 years ago. Do they still persist? Well, in JBJS, we just published this study looking at more recent trends in racial disparities. And you'll see here, when you look at from 2011 to 2017, there remained this persistent disparity and actually widening disparity in utilization of shoulder replacements. And that's when you compare it to hip and knee replacement, there's actually a widening disparity compared to the hip and knee. So we're actually doing worse in shoulder than we are in hip and knee arthroplasty. The hip and knee arthroplasty aren't doing great. They still are having a widening disparity, but shoulder arthroplasty is widening at a much greater rate. And when you break it down by reverse or anatomic, this is fascinating to me. So reverse, I just showed you, is one of the ones that's increasing the most. And yet there's this even more robust widening disparity in reverses compared to anatomics. And so it's just this fascinating concept of why is there this factor that is impacting these utilization rates in such a profound manner. We looked at all these other characteristics. So age wasn't really different between Black, Hispanic, and white. There's some subtlety differences in gender, some subtle mixes in pair mix, and naturally these all could have had a slight impact, but we did do a multivariate analysis showing even when taking account for Medicaid status, there still was not an actual impact on utilization rates. And this kind of highlights the univariate analysis looking at overall cost, non-home discharge and length of stay, once again being significantly different between racial groups. And then this looks at the multivariate model, once again showing that there is a big difference with non-home discharge, extended length of stay, and overall cost when looking at race as a factor, which once again just does not logically make sense unless you open your eyes and you realize that there is this is real, this is present. And there's hard data to support this, and something that I think we have an obligation to sort of not only look into, but to try to understand if there's something we can do about. So we've been looking at this about why utilization in disparities exists. These are some of the core team members that have helped us. There's others that I haven't, but Alex Dawes in the upper left is the one who really kind of pioneered this, and Lawrence Harvin also was a really instrumental in doing this in the bottom right. And then Ellie and John have also helped us to really take this to another level. We are in the process of looking at, from an elective standpoint, our colleagues at Grady have done a nice job from a trauma standpoint, but from an elective standpoint, so what are some of the factors that have influenced not only utilization rates or physician decision making, but also early outcomes and complication rates? And there's many different things that we're looking at. Insurance status obviously is one of them, but we're also looking at other things like patient preference, occupation, education level, a variety of other things to try to understand, is there something that is intervenable? And if it is intervenable, what is that thing that's intervenable? What can we do about it? So here's one. So we looked at the insurance status and found that Medicaid patients had higher complication rates, reoperation, length of stay, and resource utilization in primary total shoulder replacements in a propensity match analysis. So propensity score match analysis. So once again, a non-medical problem is increasing complications, increasing resource utilization by purely insurance, which once again, when you're going through med school, this really shouldn't be the case. Others have shown this also happens in hip arthroplasty. George Guile, one of my colleagues, showed that in hip arthroplasty, he found a very similar outcome where we have higher readmissions, reoperations in these Medicaid patients. And this is kind of a cool study Ron Navarro and others did in the Kaiser system. So in a universal insurance where you had similar outcomes with races, and these are clinical outcomes, but you still had lower utilization rates and you had higher rates of ED presentation. So once again, you standardize insurance and you standardize access of care, almost like you would in Canada, you still have these utilization rates that are lower. So why is that the case? And what would explain that? This is in shoulder replacements. Once again, you found a similar outcomes, but lower utilization rate when you standardize for insurance. And Ron Navarro's done a really nice job of introducing this problem. And now I think it's our responsibility to try to figure out why and if there's something we can do about it. So geographic factors also is important. So obviously we know that in this widening gap that we previously talked about with these major procedures between blacks and whites, with more and more, there's a component of geographic geography playing a role. And this is a study looking at rotator cuff and how many patient decision-making, both from a provider standpoint and the patient deciding to do surgery, is associated with geography. This kind of shows a heat map for utilization according to where the patients live. And you can see, I mean, it's just remarkable, the differences in utilization spread throughout the United States. Social factors is also relevant. So social economic status has been shown to impact the engagement during pediatrician visits. It's been shown that certain factors in the social support setting are different. So potentially home support's different, or anxiety or depression, or improvements in ADLs, all kind of maybe associated with social support. Once again, another study looking at discharge to home, as we kind of showed, there's blacks and whites are more likely to be discharged to home alone compared to Hispanics and whites. And then skilled nursing facilities, the rates of skilled nursing facility admission, as you can kind of see here. Then you look at kind of access issues. So unequal access, I think, is a real problem. This is in Oncologic, showed that Black race and female gender actually had lower cancer surgery rates at these high volume institutions. There's other studies that have showed that access is a problem, whether it's insurance or from race. You have lower rates of total knees and total hips at high volume institutions. And we do know in a variety of studies, the high volume institutions tend to have better outcomes. Patient preferences is also important to consider. So potentially this study had universal insurance and access, yet there was still a disparity. So maybe there was an aspect of this being the patient's own personal preference that contributed to why there's still a disparity. And this kind of highlights, potentially it's an expectations thing. So potentially it's how they think they'll recover. There's many studies looking at the willingness to undergo in total hips and total knees in this sort of Johnson County Osteoarthritis project. We did a nice job of sort of standardizing patients, but still found Black patients were less willing to undergo total knees. And there was a difference in perception of benefit after total knees. So meaning that different races, people from different races thought that they would benefit differently after total knees and total hips. And so this is once again dealing with a patient trust and patient confidence thing, and kind of goes back to a model I'm going to talk about, is this idea of groupthink or familiarity with these procedures. And so patient trust, I think, is at the core of a lot of this. And naturally, as many of us know, there's a long history in this country of where this trust was broken, especially with regards to research. But I think even in the medical field, it's still not completely restored. And this, the Black patients' willingness to undergo surgery really dealt with their trust and was correlated directly with their trust of the healthcare system and the providers within the healthcare system. And that the ones that did not have trust in it were much less willing to undergo surgery. And these trust scores are not only impacting the utilization rates of various procedures, but also their willingness to undergo surgeries. To undergo investigative studies or research. Mistrust leads to higher rates of missed appointments, ignoring medical advice, but postponing needed care, and even prescription refills or failing to even fill the prescriptions initially. So mistrust is a big problem. And this is something that I do think is intervenable, and we'll talk about sort of at least some of my ideas and my research team's ideas on how we can intervene on this. And at the base of all of this, trust it deals with gaining a patient's confidence. Because if you don't have a patient's confidence, if you don't have their confidence as a provider, or if they don't have confidence in either their team or the procedure, they're going to have lower post-operative expectations. They're potentially going to get to lower ultimate levels of their recovery. And have a higher expectation that they might actually have complications after this. And if you believe it enough, potentially it might actually come true. And once again, so these are starting to see, and hopefully you're understanding, there are some of these things that are intervenable, and potentially there are things that we can do to correct these disparities, not only in utilization, but also in some of the outcomes after these surgeries. So these are all different resources, all different institutes that have funded some of these initiatives. I mentioned in 2003, 2004, that was when a lot of the attention really started being paid attention to. But as you know, even though we were throwing all this money or started to throw money at it, we didn't really find good answers quite yet. As you can see, there still are real disparities. And even in 2004 at the AOS, when they really started bring attention to this problem, we're in 2022 now, almost 2023, and we still have this disparity, and it doesn't seem to be closing. And so I think that maybe it requires the field to take a step back and figure out what can we actually do to help this non-medical problem that seems to have such a big impact in patients' decision-making, their confidence levels, their utilization of procedures that can significantly help them. Total hip and total knees are two of the most successful procedures in all of medicine. This goes back to this study. So we're looking at these many of the factors I just listed off to you. We're looking at those in this sort of questionnaire survey. Every patient undergoing elective upper extremity surgery at MSK is getting this questionnaire, and I think we're going to start to understand some of these disparities and potentially find some ways that we can intervene on this. There's been some great work in sort of conscious and unconscious bias with Michelle Coleman that we've also been working on and paying attention to. She with regards to both the interview process for residencies and fellowships, as a sort of department initiative in general. I do think physician bias is important. I do think there is unconscious bias. Anybody who's taken that survey realizes that there is an important sort of unconscious bias. And that like this in clinical vignettes, Black women in these clinical vignettes were more perceived to likely have inadequate social support. Just purely based off of race, everything else being equal in those vignettes. In this case, cabinet recommendations, Black males were less likely to be recommended to undergo surgery. I think communication is an important thing. And this is a study that showed that physicians were 23% more likely to be verbally dominant and less patient-centered when interacting with Black patients. There's when dealing with patients who have problems like uncontrolled blood pressure, Black patients had the shortest visits. Gabby O'Day has done a beautiful job. This is one of my colleagues in the NATF, the AOA's NATF, that just sort of underwent, and she's done a really nice job in highlighting the disparities within orthopedics and within our not only our orthopedic training program, and fellowships, but also within our field in general. And then I'll one of these days we're going to bring her to one of our upper extremity grand rounds to give a talk on sort of a lot of her work on this. And I'd love to bring her in person someday too, because she has some just wonderful talks on the how we can sort of solve some of these problems and some real life solutions. But I think training is important. You actually look at the number of minority orthopedic residents have decreased from 2002 to 2016. And hopefully with a lot of our effort, this is starting to change, but nonetheless, it hadn't up until, about 7 years ago. And this kind of shows this disparity that seems to be widening. This also kind of shows that in academic orthopedic surgery, there is a just significant disparity, and it seems to be continuing to persist despite a lot of these efforts to overcome it. Education, I think, is also extremely important. This is something that we are going to start looking into after the first step of our psychosocial data. So this study looked at videotape education book and motivational interviews, and actually found that these all three of these active modalities increase the patient's willingness to have surgery. This was an RCT that showed that pamphlet versus videotape. It actually did improve African-American patients' willingness to undergo surgery by providing either a pamphlet or videotape. And that positive reinforcement plus education was better than education alone. So once again, dealing with a physician-centered active role in education, and there's many different ways you can do it, you can have a big impact. And this is going to be one of the things that we are going to look into. This concept of groupthink is also cool. And Alex and Lawrence were one of the first ones to introduce this idea to me. I think it's really interesting. So groupthink is, if you don't know somebody who's done something, you're going to be much more anxious about that than if you know somebody, if it's like your family member who's undergone something. And this kind of highlights this. So Black or OB-GYN patients were less likely to have heard of genetic tests, and thus they're going to be more hesitant to do them. Black psychiatric patients were less likely to have heard of SSRIs, and thus are less likely to be adherent to them. So this idea, if you've not heard of somebody undergoing surgery, like a total hip replacement or a total shoulder replacement, you're going to be much more hesitant about that procedure than if your mother underwent that procedure, or your sister underwent that procedure. And the cool thing is that peer mentoring potentially can actually help to overcome this. And we've kind of started piloting this in some respect in shoulder replacements, and are hoping to sort of carry this further, that maybe the use of these peer mentors might actually help augment some of that active education by patients. This study showed the role of peer mentoring, and how peer mentoring actually helped change the HbA1c purely through having somebody to sort of talk to and sort of help to educate about it. So some future thoughts. I think this is a really cool area. I think this is something that, at being a provider at Emory, working in a city like Atlanta, which is one of the most diverse cities in the country, and seeing such a diverse patient population, I think it's sort of our obligation to be a part of this discovery process, and it's a bit of our obligation to help be the solution. We've sort of taken this by the reins. We have at this point hundreds and hundreds of patients that have given a variety of different a lot of information on potentially answering the questions in elective orthopedic surgery, why some of these disparities are existing. And we are using some of the preliminary data to already start designing some interventions like education, like peer mentoring, like some other stuff that I think is can be easily studied and can be easily implemented to a large population relatively quickly if we find some really powerful results. If you can't tell, this is something that I think I would sort of encourage anybody listening to this to sort of take it by the reins. We are always looking for collaborators. At Grady, they're doing a very similar, slightly different focus, but a very similar program that has already shown some really nice results in the trauma population. It's interesting that disparities in the elective population are even more profound for whatever reason. And I think this is something, those of you who do elective surgery, I would sort of call you to sort of help with this. Gabby O'Day on my traveling fellowship, she's done a really great job of looking at the workforce and disparities that happen in the workforce, and not just on those entering orthopedics, those staying in orthopedics, and those eventually becoming leaders in orthopedics. And I think whether you're talking about disparities with regards to orthopedics, whether it's women, whether it's Black or Hispanic patients or other ethnic disparities, whatever it is, I think it's important to continue to bring attention to these disparities. But personally, like, I'm not a big one who likes to just call attention to stuff, because I think, as you showed in 2003, by calling attention to stuff, it doesn't actually correct it. I think kind of my mind goes to, fine, there's a problem, but what are the solutions to correct this problem? And what are real actionable solutions? And hopefully we can bring Gabby in. I think she'd be a great one for, or Dr. Day in to talk to us in general about her thoughts on the correctional, on how we can sort of correct this going forward with regards to a diverse and equitable and inclusive workforce. But hopefully I can inspire some of you to take this on from a research standpoint and help to understand how we, for our patients, can provide equal access, and not just access as in, hey, they have access to care, but access as in understanding and education and opportunities, if they don't know somebody, to engage in people, access to the same things, regardless your race, regardless your insurance status, regardless all these other factors that should not impact somebody's health. This is kind of hammering the point that just having initiatives is insufficient to reduce these disparities. And to really have sustained change, you have to have policy reform, sustained funding for research, and education. But you also have to have people that sort of champion these efforts and not just talk about why they exist, but how we can actually get solutions for them. This is a kind of cool study. So this looks at a group of patients where there's a active policy to reduce the disparities with regards to total joint arthroplasty within a contained group of patients. And they found in this county that they were able to, by this active approach, with regards to education, with regards to access, with regards to both patient and provider education, they were able to close this disparity. And so it can be done. It can happen. Here at Emory, I think it's our obligation to study this and to be part of this change. This is my email address. Reach out to me if y'all have interest in this. I think it's an easy collaborative experience. We've already started talking to other very diverse cities like Chicago and New York to also participate in some of the studies that we're doing, and obviously happy to have any other collaborators. So thanks for the time. Thanks for this opportunity. I hope to give another chance to talk about this in maybe 6 months, because I think we're gonna have some cool new data coming out in the next couple of months. And we'll hopefully have some new initiatives coming around. So this is a good time if anybody wants to jump on board with our study. We're about to start a new phase of this study and would love anybody to join on. So thank you, and please reach out to me if you have any questions.
Thank you so much, Dr. Wagner. We really appreciate it, and that was a great presentation. We'll go ahead and open it up to Q&A if anyone has any questions. I'll go ahead and start us off. I was wondering if you could give a little bit more details on that last study that you showed, where it showed the closing of the gap of disparities. What kind of approaches were they using, if you have those available?
Yeah. So it's a great study. Happy to send that out to anybody who's interested. And basically what they did in this sort of like small setting, it was like basically like a small county, is that they sort of implemented, and I think it was actually run by the county, but the providers within it were all had a certain training. They all had education pamphlets that were given out, and there was a sort of a uniform education that was being provided for anybody undergoing a total joint replacement, total hip or total knee replacement in this county. And what they did is by unifying everything and creating easy, accessible education and standardized education, they sort of got rid of that whole groupthink thing that I was talking about. And they got rid of I think a lot of the anxiety that underlies these procedures. And I think it also overcame the fact that a lot of orthopedic surgeons have a pretty busy clinic and don't have 30, 45 minutes, 60 minutes to spend with patients explaining all the risk benefits and more importantly, probably all the expectations in the detail that maybe it deserves. And so this kind of helps those patients who are not as familiar with some of these surgeries to have this sort of equal access to education. And purely by doing that, they're able to reduce. I'm happy to send the study out for anybody who's interested. But it's a very it's maybe not the perfect perfect example because it's a small, it's not a major metropolitan area like we deal with. They don't have all the barriers that we deal with here in Atlanta. That being said, it shows it can be done. And I think and I think we're going to be able to do the same. Like I think the groupthink mentality is really powerful. That's what we've seen in some of the preliminary thing. If you don't have family members who've had undergone surgeries or are familiar with this, you're just not going to be, you're going to have way more anxiety about it, and you're going to have way lower expectations. So I think education, I think the peer mentorship is actually going to be a really powerful thing. I've piloted that now a couple of times already, and we're actually going to write up a case study on it. That I think it has a sort of profound impact. We actually did the patient I'm talking about. The first time we did we did a shoulder placement on the patient's husband, and there was a ton of anxiety with this, both with the patient and the husband, about the surgery, and quite frankly, like did not do as well as any of us were hoping. And then with her, when she underwent it, I actually put her in contact with another patient who had had a very successful, very similar surgery. And she reached out to him. They had like, I think just one or two conversations about it. And she like flew through the surgery and did phenomenally well. And I cannot help but think that the peer mentoring played a big role in that. And it did not have anything to do with what I actually did.
Thank you so much. I really appreciate that. It looks like we have a question from Dr. Bowden. I'll go ahead and unmute you, Dr. Bowden.
Dr. Wagner, thanks for a great presentation. Do you think that if we're presenting, a surgical option to someone and they say no or seem reluctant, do you think that that's the point where if we had maybe an educational video for that general category of procedures, we'd say, you know what, let's not make a decision today. I want you to, go home, get online, watch this, and let's either come back and talk about it or do a telemed and talk about it. But do you think, somebody saying no when, you think they probably ought to be saying yes, or you're worried they're saying no for the wrong reasons, is that the intervention point? Is that the sign we should watch for? And, how tough would it be to develop, a couple of videos that are touching on the most common reasons that people are reluctant, whether it's trust or, disruption to their life or skepticism about the result or whatever?
Yeah, no, you hit it on the spot. So that's what we're actually using that survey questionnaire that I showed you earlier. Is we asked all those questions to try to develop some of the highest things, try to figure out what are some of the highest anxiety factors when deciding to undergo surgery, to then design our interventions based off of those factors. So yes, I think that's very easy to do. I think the study I want to do is that, the intervention study that I want to do is design a educational intervention, like you said, a video / pamphlet, and maybe study different interventions, but and look at and look at it where you don't make patients make a decision. You come in, you introduce an idea. Hey, you're a candidate for shoulder replacement. However, before we go through about making this decision, I want you to watch this video, read this pamphlet, whatever it is that intervention is, that talks about some of the most common anxieties that we found in these other questionnaires, and then have the conversation with them. I think that's a nice step. I don't think it's the only solution, but I think it's a nice step, because that that I think will help to equal the access to education part of it, and normalize maybe the ones who don't know people who've undergo it and maybe haven't gone on Google and read as much about it versus those who have done all that stuff. I also am really curious, Dr. Bowden, and I'd be curious your thoughts too, is I wonder how powerful it is to coming from like me as a surgeon doing it, so a generic person doing it versus like a patient talking about their experience with it.
Yeah, so
Um,
my thought was, designing a patient education brochure that's kind of, I would scripted would be too strong a word, but the topics are directed based on your survey results. But
Yeah.
one question I have for you is, do you think the list of reasons that people say no when they should say yes is going to be different for a total shoulder arthroplasty or a back surgery or a knee replacement? Or do you think it's going to be the same factors? Because the common thread in your whole talk is, the saying no when you should be saying yes is racial disparity. And it seems like it's for every procedural intervention. So I'm wondering if there could be a generic sort of video that's not procedure specific, and then we could intervene with, look at patients that watched the video and didn't watch the video and see if we can, study it throughout all of MSK on the big major procedures: total hip, total knee, total shoulder, back surgery, whatever it is, and unless, if you think it's not procedure specific.
No, I think you're right. I don't think it is necessarily procedure specific. You might be able to separate major versus minor. But we've even actually seen a disparity in just anxiety about surgery with regards to carpal tunnel release. So I do think that I think that would be a phenomenal study if we could do it across specialties.
I think if you could make the patient, video with vignettes that are, people are talking about the 5 most common topics why people are afraid or reluctant to commit to surgery, we string that into a non-procedure specific video, then across the department, we could use that as an intervention and see if it has an impact on closing the racial disparity on going forward with procedures that are probably indicated.
Yeah, that would be awesome. That would be super powerful if we could do that. Yeah, I mean, I would be very interested in that. I also be, and then based off of that, we could, anyways, we could also look at other, like, is it more generic versus specialty specific? I really think the peer part, the peer mentorship or the peer hearing from peers is a very powerful thing. But yes, no, I think that would be incredible for start. Yes. So, like I said, we should have all the data from I think we have 800 plus questionnaires at this point. We should have all that by the new year. So, I will ping you again about once I kind of come up with content about helping, if you don't mind directing me who I can get to help with to create this video.
Sounds good.
That'd be
Hey, Dr.
super
Wagner,
powerful. Across
great
all
talk.
interventions, that'd be super powerful. Sorry, go ahead, Doggy.
Hey, great talk. Certainly appreciate your passion for problem solving. From the provider side, what do you think is the sort of value of a provider that may represent, the ethnic or racial diversity of the population they treat as far as utilization rates and outcomes?
Oh, absolutely. I mean, that was what I was getting at with Gabby and or Dr. Day. I think that's a very important aspect, and it's there are studies that suggest with regards to not necessarily outcomes, but with regards to utilization rates, that it is different based off of race, based off of gender, based off of even honestly, there's even studies on religious status, interesting enough. So I do think it's important. I do think it's impactful, and that's why I want to bring Dr. Day out, because she has some really nice data that she herself has studied, but she also has some really nice solutions on combating that problem. Because we've been talking about that for 20 years or 15 years. Ever since I got into orthopedics, I've heard us start talking about this, and it doesn't seem to, nothing has seemed to have stuck well so far. We have closed it, I think, in some small amount, but I think not anything meaningful. But that's why I would love to bring Dr. Day out, because I think she has some really cool ideas. She presented them at our NITF or across at various places. She has some really cool ideas on how to actually combat that question.
Got it. Look forward to it.
Yeah. So to answer your question, I think that is important. But I think to intervene on this, besides just talking about it, I think there has to be some sort of intervention, and that's why I want to bring Gabby out, because she has some actual like meaningful, hey, like she has a like kind of plan on how to actually close that gap, which that we know there's a very large gap in that respect too.
Thank you, Dr. Wagner. If we have any other questions, feel free to send them in. We'll give it one more minute. Also, while that's happening, I'll go ahead and send the link. If you're interested in joining our team with Fossil, please fill out this form. I'll also email this out to all attendees afterwards as well. I guess
Amazing, everyone. Well, thank you all very much. Reach out to me, please. It sounds like I might be roping Dr. Bowden into making this an MSK-wide project, which would be amazing. But in the meantime, those of you who are individually interested in this research, there's plenty of it to go around. We have lots of very passionate people that are involved already from a research standpoint, trainee standpoint. So it'd be nice to have some more providers. So please reach out to me. And the bigger the better in this type of study, because the more people we can get involved, the more powerful our conclusions, our interventions will be. So please reach out to us. Okay.
Eric, can you think of somewhere that you could write a grant once you have the data on the topics to include in the educational videos, where we could actually get the funding to make the videos and then test the intervention?
So I have full plans on turning this into in a NIH. There's a whole subsection. I'll have to remember. I was the
Health disparities.
Yeah, whole subsection that the NIH has in health disparities. I'll have to. I wrote down. I was talking to the Stanford people about this, but but there's a whole subsection that really this is very applicable to, and especially if we can get institutional buy-in or multi-center buy-in, this is a very applicable area for funding that we can not easily, but we can, if we can make a profound effort to get some preliminary data, I think we can do a nice job of doing this. Also, the is it P34, Dr. Bond? The sort of investigational aspect of things. There's a whole funding mechanism for investigational projects, like initiatives or pilot projects on disparity related research. And so potentially we could even target that, but I'm looking at more of a bigger picture one, where we like test multiple interventions over a long period of time. So I think this could be turned into a really cool study section for our division/department to take on if we're so interested. So
yeah, I mean, you could compare an educational pamphlet to a video to a peer group, because each of those are increasingly more complicated to administer, and see where the cost benefit gets the most bang for the buck as part of an NIH grant.
Absolutely. And we already have pre-op joints classes. We could literally start even incorporating those as some interventions. So I mean, there's lots of things that we already do that we could easily implement, and I think we could have a multi-phase sort of grant that could support that. So I think it'd be a cool direction for us as a department. So.
All right. Well, I don't think we have any more questions. Thank you so much for coming out, Dr. Wagner. Thank you for everyone who attended. We really appreciate it. And please get involved if you're interested.
All right. Thanks, guys. Have a good night.
Thank you.